Hello, now we're going to show you the intraoral landmarks on our compliant but not happy victim. No. And I'll show you how much we inject each side. No. Okay, so let's start with the mandible. She has a ramus, and if you look in her mouth, in fact, let's shoot on this side here. Take a look at how we have this beautiful triangle. Open a little more so we can get the light in there. Can you see that? You see this triangle here? This inner edge, right next to her tongue, is the pterygomandibular FA. And this outer edge is where her ramus comes down. So you have a triangle there. And this is the occlusal plane, top of the lower teeth. And we want to inject about a millimeter, or a centimeter higher than the occlusal plane. And in her mouth, the pterygomandibular FA starts for the mandible, goes the pterygomandibular bone up here. And you can see how the deepest point is about right there. See, it starts curving back forward towards the maxillary tuberosity. So our injection site is right there, about the deepest point. And that happens to be about 1 centimeter higher than the occlusal plane. So our injection site for the inferior alveolar nerve block would be right there. And because I can feel that her ramus flares out a little bit, not too much, we could come in slightly over by the premolars on the opposite side, drop it right in, and about 2/3 to 3/4 of the depth of the needle is where we stop and deposit once we touch bone. And we can estimate that depth just by knowing how deep the needle is, but also if you take a look here, I'm grabbing the back of the vertical aspect of a ramus and the coronoid notch, and then I can feel it's about this big. So you know the tissue kind of hangs in front of the bone a little bit. You're going to need to go back about 3/4 of that distance. Then the lingual nerve drops off right on the inside here, on the inside aspect of the pterygomandibular FA. So when we go back to do the lingual block, we go back to the same site and don't go back quite as deep, maybe a half or so of the depth of the needle, maybe even a little less, and you deposit about half a carpule, and that will numb up all of her lingual gingiva to the midline. Then she has a long buccal nerve that runs across the outside here, and right where that little red spot is, that would be a perfect spot to deposit the anesthetic to numb up the buccal tissue up to the end of the, in her case, implant or mesial aspect of the first molar. And you want to inject right on the lateral side of the attached gingiva, and you can see that we're getting that softer tissue. When you can deposit into softer tissue, it's better because the anesthetic can be absorbed easily. So then on the upper arch, what we'd want to do is have her close a little and slide her jaw to the left if possible, so that when we're doing the posterior superior alveolar injection, we can slide around behind. See, I'm really going way behind and above that terminal molar. I'm not going straight up here. I'm turning the corner and going behind the bone and depositing it right there. Can you see that okay? Mm-hmm. Then the next injection, that was the PSA, the next injection is the MSA. The MSA is deposited above the second premolar right here. And the ASA is pretty much above the tip of the canine here. Then the palatal injections, open kind of wide and turn to the right just a tiny bit, thanks. If you take a look, the tissue is nice and hard, solid, and we get back here and it dips. You see how I can dip that? Look, Here, doesn't move, doesn't move, doesn't move, doesn't move. Boom, drops right in. That's where your fossa is, right above the foramen where the greater palatine nerve drops out, or comes out of the cranium. So you would put topical there and inject slowly to numb up all of the tissue from the maxillary tuberosity to the canine. The nasopalatine injection is underneath this little football here. She has perfect representation. The nerve comes out of the nasopalatine foramen kind of low, lower than it looks. So your injection ideally is right about here. So you would inject right there to numb up the tissue, just the tissue only, canine to canine, with a little overlap with greater palatine. Or to numb this up, we come out here and we inject just a little bit under the foramen here, under the frenum, so that the tissue is nice and soft and absorbs anesthetic easily. That gets her numb. Then we can inject right here between the two centrals and slide it forward just a little bit. And then you'll see the papilla between 8 and 9 turn white. It'll be a little blanched, and then wait for a moment. Then you can inject right here, and the entire nasopalatine nerve will be numbed up. Takes 3 injections, hurts a lot less. Now let's talk about topical.
Will you show them a mental to
Yes.
Dr. Morgan?
Yes. Okay. All right. Let me find it on you. Okay. So another injection we can give is the mental. The mental numbs up the tissue to the midline from about 3/4 of the way back on the second premolar. The way to find the mental, it's kind of low. You start with your finger above the first molar, slide forward, and you'll feel depression. You can even see it perhaps. So we have this kind of buccal prominence, 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 and then boom. See how it drops in there? There's a depression. That depression is a fossa right over the mental foramen. So you can go find that location. You can look in the radiograph. Sometimes it helps you too, because occasionally you'll find the mental foramen closer to the first premolar, but usually at pretty much the tip of the second. And then you can deposit your anesthetic over top of that area and then press with your finger 1.5 to 2 minutes, and we'll soak right in there and numb that tissue up very nicely. So then let's talk about topical. For one site, you'd use about this much topical. Not too much, because the topical is local anesthetic, it is a drug, and it adds to the burden of your own other anesthetic. And sometimes, as you know, esters are much more likely to create allergies, and topicals are esters usually. So you don't want to put a pile in there and find out this person is actually allergic to esters. Whereas the lidocaine is an amide, not too many people are allergic to it, perhaps no one. Now, topical anesthetic does not penetrate well when the tissue's wet. So you take gauze. Some people actually advocate drying it with a little air. And once the tissue's dry, you see that tissue's dry, then we place the topical like that. And ideally, you let it soak in for a minimum of 1 minute for it to be effective. It will continue to be even more effective if you go over 2 minutes. And that will allow you to sneak that injection in, and in a fairly painless manner. Is that good?